Welcome back to Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Physicians for a National Health Plan Kentucky chapter is our affiliate. The views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. For more information about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org. Kay Tillow is our chairperson. You can reach out to Kay with suggestions or comments by emailing her at nursenpo@aol.com. That's nursenpo@aol.com. Our host for the program are Dr. Mike Flynn and Dr. Eugene Shively. Dr. Flynn?
Yeah, let me begin with the usual disclaimer that the comments that I'd make here are my personal views and do not in any way represent the views of the Department of Surgery or the University of Louisville.
The comments that I make do not represent the views of Taylor Regional Hospital in Campbellsville, Kentucky, nor do they represent the views of the University of Louisville or the Department of Surgery at the University of Louisville.
So our topic today is telemedicine, something which I've learned some things about and knew actually very little about before we got into this. And our guest speaker is Mary Berry. I'm going to partly introduce Mary and then let Mary partly introduce herself. Mary, I've known Mary for over 30 years. She's practicing internist in the Norton system and was, I think, recognized as one of the premier internists in the city. So Mary, explain to us how you got from being one of the best internists in the city to practicing telemedicine.
Well, the two things, well, thank you for that compliment. And the two things are not actually separate. I gave up my large practice that I'd had for over 30 years in December of 2019. I took January off of 2020. In February, I started working for Norton's just as a float doctor. That meant I was the fill-in doctor. I would see whoever woke up sick, which is my favorite thing to do, sick people. And that worked great until COVID hit. And when COVID hit, we did not want you to come to the office if you were ill with any respiratory symptom or any symptom of COVID because it exposed too many people. We wanted to see you where you were. And so telemedicine from there, and Norton's did all the heavy lifting of the informed consent, the staffing, the fixing it up, et cetera. Okay, I just had to do the doctor part.
Yeah, it's great. So what we have done with our other guest speakers is give you an opportunity to make whatever comments you'd like to about the topic. So we're going to give you an opportunity you can just line out what you'd like to talk about, what you think's important, or whatever you'd like to say about telemedicine. And then when you're done, we'll begin the conversation.
I hope telemedicine is here to stay. It will depend on the continuance of the National Public Health Emergency Declaration at the moment. And that has been continued until April 21st. After that, it will depend on doing it over or ending it altogether. So we can continue every 3 months. We can keep having a national public health emergency. All the payment will same, the regulations will be the same. But once that emergency is over, telehealth goes back to being what it used to be, which is only paid for by Medicare if you live in a rural area and leave home and drive yourself to an approved health facility in your rural area to consult with an out-of-town expert. So far, that's all it used to be, unless you count remote monitoring, ICUs, and that sort of thing.
Gene, go. You want to start the first fire?
Well, how satisfied were you with using telemedicine? Did you think that you got a good history? And what about the physical examination?
Well, that's really all about patient selection. I can tell you about a guy I saw that he told me where he worked, and I just turned that place in to the health department for not wearing masks and not enforcing anything. And I could look at him and tell him had COVID because I could tell by his eye. There's a COVID eye. And as soon as he came on screen, he looked sick. I thought, oh no. And what I did for physical exam is got him to exert. I had him walk up and down the steps several times, and he was gasping for breath. And I sent him immediately to the Audubon ER. I told him to pull up and lean on the horn until the cops came out to check on him, and to keep the window rolled up, because that was all the physical exam I really needed. I had the eye and I had the exertion, and, I talked to him, of course, and told him a lot of encouraging things, but basically he had to get there quick before he ended up on the vent.
So now, were you seeing new patients? Were you seeing follow-up patients?
I was seeing other people's patients because I was the float doctor. So mostly I saw people who had an acute problem or needed a quarantine work note for COVID, which was a popular cause, or needed something. They had rashes. They had something that we could generally see. Anyone with a belly problem, I made them show up. It depended on the nature of the complaint. With bad medicine, to do things that require a physical exam, to do that on television is a very bad medicine. And so if I required them, they would come in.
Mary, let's kind of go back to the basics. One of the titles I've got here is hardware. So what can you use or do telemedicine on? You've got your desktop computer, your laptop, a cell phone, an iPhone, a flip phone.
All of those things, your iPad, and just the telephone. Medicare is paying for phone only and all forms of video. And right now, HIPAA has been set to the side, and no one will be penalized for any HIPAA violation by using Zoom or Skype or FaceTime or one of the non-secure links until the COVID pandemic and the national public health emergency crisis are all over. And then they'll go back probably.
Do you, if you had an option of prioritizing these various hardware options, which way, which would be 1, 2, 3, and 4 in your opinion?
Well, the easiest for people to use was FaceTime because they're used to Facebook.
Sure.
And we could write our office note on the computer with the split screen and have them on the other side of the computer, have the visit going on. So Zoom or Facebook are pretty much tied, but the one that people had least resistance to using was Facebook.
So how did you decide which mechanism to use? Did you call them?
Our staff, this is Mike Needleman's office. I'm working out of Allspring and Okolona, and he had a fabulous staff. And the staff figured out how to hook people up so that they actually showed up on our screen. And that would take, if you had a telemedicine appointment at 10, maybe back 10:45 sometimes, we would have figured out how to hook the person up, because not everybody was competent. Sometimes you just had to talk on the phone, but they did all that hard part.
So you had staff that would hook up the patient, like, for example, on WhatsApp or Zoom or whatever. And then after they did all that, then you would get on the screen or the telephone and then talk to them.
Right. And just the same as always talking to people, I would start out with what's the matter and see what was on their minds to talk about.
Now, did the staff put in the past history, the review?
Well, that was already in the Norton system. That's already in the electronic health record. It's in the Epic note. Okay. I have access to their medicines and their surgeries and their family history, and all that is, built into the computer. And I don't have to read people's handwriting, of course, which is like mine, which is not readable.
So did you review that before you got online with them?
I would look at it, yes, especially when I'm waiting around. I always looked at it, especially allergies and, are they scary at all? What kind of medical past have they had? As an 85-year-old frail lady that now has a hip issue, that could be major. She could have broken it and hardly known. So if it's real tiny. So basically, I always reviewed it.
Okay. Do you think that you could do this alone, or do you have to have backup medical staff who's an expert in hooking them up?
Alone if I signed up. Say I got tired of just being a dog mother and I decided I would do telemedicine only. and I signed up to work on Teledoc or AllMed. Those are platforms that you just hire on as an individual doctor, and they supply the platform and stuff. I would be able to do it that way, which I don't, because I don't like not having the option of examining a patient. I don't think that's good.
Mary, what specialties or medical disciplines are best suited for telemedicine? We had Jess Wright from psychiatry on in the past, and recently had Rob Campbell, who's up in Ohio doing addiction psychiatry, and they both indicated that these areas, seem to be reasonable things to do with telemedicine. And I was thinking as I was driving in here this morning, well, I spent the last 10 years doing thyroid surgery and, evaluating people with thyroid nodules and goiters and things like that. And I don't see how this would work, because I can't put my finger, I can see your neck on the screen, but I can't touch it and feel it. And
it will never replace anything that requires a physical exam to be adequate or good medicine. It will never replace that.
Right.
It's the talking disciplines, social work and counselors and psychologists, and then check up things like somebody sent home from the hospital and they've got 10 new heart failure medicines, and they have to figure out how to weigh themselves. And you can send the doctor who discharged them can do a follow-up visit. So they're talking to the doctor they already saw in the hospital and their nurse practitioner. So follow-ups of all kinds that involve looking at the patient, but not having to touch the patient to really get an idea of how they are.
yeah, I think, and I'm just thinking, Gene, that, I think post-operative visits to some extent would be reasonable to do some things on telemedicine. I mean, somebody can pull their shirt up and show you their gallbladder scar, or
they do that with the spine surgeons, and sometimes the other surgeons, they can look at their knee or look at their hip. And you can ask your questions from the patient point of view. You're asking the doctor the question. You're not asking the therapist and hoping the therapist will remember to ask the doctor and report it accurately back.
Okay, what about the confidentiality and HIPAA laws? If let's say a year from now, this endemic has gone away, but we're still going to use telemedicine, how will we deal with confidentiality and HIPAA laws?
Well, there's a way to do that. There's an informed consent that the staff would go over, but there are platforms that are already HIPAA compliant. One is Skype for Business, UpDocs, Zoom for Healthcare, something from Doximity called Doxy.me, and the Google G Suite Hangout. That's just a list that I've found, and they already are HIPAA compliant. So we just have to work to make sure it's HIPAA compliant. In the rush to get online, they just said, let it go, just talk to the person. But eventually it will have to all be HIPAA compliant.
What about recording? Let's say you're on Zoom and you're talking to the patient. Are there programs that record the patient and record you?
Well, if we originated the Zoom, I guess we could record it. I don't think that we did record it, but maybe they recorded them all because of lawyers. I have no idea. If later somebody sues me, they can say, this is what she actually said. It never occurred to me at the time. So it can be recorded is the answer, but I don't know how it would be used.
You've already partly addressed this next question that I've got, because it seems to me that telemedicine is a good option for underserved populations in either rural or urban areas, and older people.
Yes.
Who find it difficult to do the in-person visits for a whole assortment of reasons, whether it's physical, economic, transportation. But at the same time, these are the groups that are the least technically savvy and capable. So you've got, on one hand, you've got the need, and then on the other hand, you don't have the skill set. And I guess you relied heavily on your staff to do these things.
To get in on the other end, people who were really had difficulty communicating because they couldn't hear well or couldn't speak well or
Yeah.
were beginning to lose it upstairs. They had a family member with them who was better at handling the technical parts and answering the questions and making sure someone remembered the answers. But you can do nursing home visits can now be done. Emergency room visits have telehealth now. You can do telehealth in any setting in any state. The interesting thing about the regulations is that previously you could only practice telehealth in Kentucky if you had a license in Kentucky. But because of the doctor and nurse shortage, Kentucky had an emergency declaration and will take any doctor from any place or any nurse from any place with a valid license there and let them work in Kentucky. So I could doctor people in Texas if I felt like.
So give me
This
an
is all
example.
the national emergency. This is not normal operating.
Right, I understand. Give me an example of how you would do an emergency room visit. If somebody calls in from their bedroom or
It's
their laptop.
triage. It's LA has done this. It's triage by the EMTs because right now the EMTs only get paid for a run if they transport the patient. And so they transport all kinds of people that don't really need to be transported. It requires all kinds of new payer agreements, and I'm hoping the new administration will help to fix that. But what they do is they get on telehealth with somebody in the ER, and the EMT says, it's this, this, this. And really, I think that they just need to go see the orthopedic surgeon tomorrow. There's nothing major. And then they help arrange the follow-up to the orthopedic surgeon who's on call for the ER. And so that's a telehealth visit that you didn't have to transport, but then also they didn't get paid to do.
So a lot of that is basically triage.
Right. Except they got paid for the telemedicine part. They just didn't get paid. They can get paid for telemedicine, and not transporting.
Right.
If they just decide on their own, they don't get paid.
Now, who's theoretically going to get paid? The ER, EMS?
The EMS.
Okay, EMS. And then how do they get an appointment with orthopedics? Because my experience in getting appointments with orthopedics
Right.
has not been good.
Because the ER has it on call. You have to take call if you're an orthopedic surgeon and privileges, you have to take call. And so the ER just, they page Dr. Flynn for endocrinology, surgical oncology emergently. They would page the orthopedic on call and get the person an appointment the next day as part of being on call duty.
Okay, so have you had success with that? Let's say somebody's having severe pain in their knee and they do telemedicine and it looks like it's an acute problem, but not something that has to be seen today. And so the ER calls the office and gets an appointment. Now, my experience is
they have in LA. They're doing this in LA for a while, but I don't know if we do telehealth follow-up from the emergency room, discharge, all COVID discharges, all heart failure discharges. And we have a virtual hospital at home set up for those people with oxygen and oximeters and all kinds of stuff. And frequent check-ins. But as far as the acute orthopedic problem, I'm reduced to begging like everybody else for that.
What do you do with a patient who you think has an acute emergency? Do you tell them to call the EMS or?
Yes, I have sent ambulances to the house, and I have sent the person to the ER directly from a telehealth visit. Most of those were related to acute COVID illness. One guy, he was having symptoms that were probably his heart, and he was in great denial. And I told him it was his heart, and it did in fact turn out to be his heart. But I sent EMS to him because he might need defibrillating, and he shouldn't be driving himself to the ER. So it instead of him driving here and seeing me, I just communicated with him telepathically, so to speak, and got the ambulance to him. He just needed somebody to tell him to call the ambulance.
Okay. Did he call the ambulance or did you call the ambulance?
We called the ambulance.
You did?
Yes.
Okay.
I kept him talking and I had him feel his pulse and I did other things, until they got there, just so that there's a person on the other end of his anxiety.
Okay. What do you do if you have a technical problem in the home? For example, they're on a Zoom and you lose the picture and you lose the audio.
If we lose both, we're done. We have to hang up and try all over again. We can do without the picture, but we really cannot do without the audio because that's the advice part.
Okay.
So sometimes it would be a phone call with a blank picture. Just the
Okay.
picture
And
with
then
that.
the people, your technical staff, the nurses or the aides who are helping you, they usually take care of that.
Yes, they would get the person all hooked up, and then they would, call us on the little office phone and say, so and so is on line 3 or whatever. I can't remember what we called it. Zoom 3 or Zoom 1, and then I would try to open the visit in the computer, and there they were. It was really cool.
Okay. And did you have a link to that visit? And did the patient have a link, or did they have a?
I never asked those questions. I'm sorry. I should have. I was just happy to get them seen and go do something else, because normally when you wake up sick people, you just go boom, 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 sick people all day. So.
Okay, it sounds like that you had your cake and was eating it too, because that's the way I would like to do telemedicine.
Right.
Somebody does, it's like me and the electronic medical records. When I was practicing, I had a nurse put all that information in, and then I'd go in and talk to the patient. And if I had to have a complete H&P, then I would use electronic medical records and what I dictated or what I'd written down to do that. But if it was just a follow-up visit, I would just dictate a note and they would put it on the electronic medical records.
Oh, you're good.
Mary, let's talk a little bit about finances. You've got the for-profit insurance companies, you've got Medicare and Medicaid, and then you have people who are uninsured and people who are underinsured. So,
right.
Who pays for what? And somebody calls, you get a Zoom meeting with somebody who's got some cardiac problems and they have some questions, and you talk for 10 or 15 minutes. What happens next? And they've got Anthem. So do you send a bill to Anthem?
The original CARES Act and the second CARES Act both provided funds to help set up telehealth. So that from the provider end, but all of those things are paid for by if Medicare covers it, Medicaid covers it, and all the other things cover it. So for a typical visit, if you have Anthem, you have to pay your office copay. The doctor or a psychologist or nurse practitioner is paid the same as always for that quote level of service visit. So it's indistinguishable in the pay structure as far as telehealth. And if you're uninsured, I don't know that you can get an appointment with an organization like Norton's. You probably have to be seen, with the homeless clinic of some kind.
Now, I've listened to a couple of podcasts about this in order to get some knowledge so I could ask you some intelligent questions. And one of the things I've learned from some of these is that they're different. This is different things in different states.
Yes.
And Medicare, I mean, now, and that's my question is, did I understand it correctly that Medicare and Medicaid cover different aspects of this in different states? And can you give us a couple of examples of?
No, that I don't know. Yeah. Medicare is national. So I think that I really don't know. I know that it's covered at the same levels. And that's by the waiver, the Section 1135 waiver, which was the declaration of the public health emergency by Secretary Azar and President Trump. That's what got it all started. And so they've said they will continue to pay it the same. The patient cost sharing is the same it would be, but I have not looked into other states.
So if you do that, you submit a bill with a code on it. Does it?
Yes, it has there's a code for telehealth that you code separately.
And then the insurance company then collects the copay from.
Right, and then proceeds to reject it or accept it or whatever they normally do.
All right.
So does the office collect that copay, or does the insurance company collect it, or?
The office collects the copay, I think, and
Okay.
Yes.
Okay. Now, can a primary care physician break even by doing telemedicine?
I don't know. There's the stock of both Telecom, Teledoc, and Allmark are both up. Teladoc stock is way up. And I think this says to me that there are enough doctors doing it and nurse practitioners, I guess, and psychologists, it's a whole lot of different people. There are a whole lot of different people to make somebody money. But I've not tried to figure out what your salary would be. In the ads, they say you would make it, 3 or 4 figures, a lot, 5 figures sometimes, just doing telemedicine. So there's a whole lot of it going on. So I think it must be profitable is my point.
And how do the the option of calling again, and my question is an example of my ignorance about this. When you were in clinical practice, if one of your patients ended up calling some telemedicine option, yeah, how do you try to work out the relationship between the sort of person's usual provider and then whoever they get in touch with to do whatever they want to do when they decide to do this telemedicine
Most of those
thing?
visits have a share option at the bottom. Please share this information with, and they just could have put my name in my office.
So you would get a copy of
if the patient that is patient directed, if the patient wants me to get a copy.
Oh, okay. That's interesting. Huh.
And did you send that to the referring physicians, or consulting physicians, to say this patient had a pulmonologist and a neurologist? Do you send all this information to them too?
And to them, if there's a couple people, I probably would have written a letter, sent a letter, and called them if it was urgent.
Okay.
But I probably would have just written a note so they don't have to read all that stuff. I can just tell them epic notes or masterpieces of boring, repetitive data. So
Yes,
I write a letter and say, here's what's important.
Yeah, but by experience, most people don't do that. Write letters. They just send all this voluminous information, and it takes a huge amount of time to find what you need, and sometimes you can't even find what you need.
Right. So I preferred letters. They were old-fashioned but more effective.
Yes, I agree 100% on that. I wish we had more doctors like you.
Let's talk a little bit about mistakes and malpractice and those issues. Gene and I have both been surgeons for many years, and as we all know, surgeons get sued. Sometimes for things that didn't work out so well, and sometimes for crazy things that you wouldn't even expect. So my question, again, this is a question out of ignorance as much as anything else, but what are the issues related to, suppose you make a mistake and you miss something, or how does that work with the what's the medical liability issue?
This has been looked at in the usual, if you're not exercising usual and proper judgment, then you can be liable. So I guess it's an argument to record all of them, and so that you have in your defense what you actually said. Although if you're wrong, it could end up hanging you. But you would testify what you actually said anyway. So, but it has been looked at, and it's the same as an in-person visit, except they have video of you saying it.
So all of these telehealth contacts, whether it's a Zoom,
it can be recorded. Whether it's recorded, I don't know.
Okay, well that was, so who makes that decision? And
if I had a real contentious person who was unhappy, for instance, the patient herself is okay, but she's got a 65-year-old really horrible son that I hate his guts, that pushes his mother around and so forth. I might record that visit.
Okay.
It depends on the situation, what I would choose to record, and I would have to have permission for, to record it.
So there's not a medical record as there is when there's an office.
There's a medical record, but not a video record, unless Norton's put that into Epic. I can't access Epic anymore.
Okay.
I'll find out from Mona Lisa Taylor or somebody if all those Zoom visits are recorded. But you're right, a note. I'm sitting there typing and talking just the way I would in the office.
Oh,
I
okay.
write the note as I go through the
Oh,
visit.
I didn't realize
Okay,
that. Okay.
so you're, in addition to talking to the patient, you're writing a note also.
The whole time I'm writing a note and looking things up and talking to them. And yes.
Okay, so the only difference is you're just not face to face. You're just on a either a audio or to telemedicine plus audio.
Right. We are distant, but connected.
Okay, so are there other ways of doing this? Can you make this conversation a permanent copy, or can you dictate a note after your telemedicine conference? Or?
Well, just the way doctors practice. I mean, I had to do it as I went, or I would never, ever, ever get through my day, and I would forget details. So I had to type as I went. And some people when I was a student, I trained with doctors that would walk out of the room and talking to the little tape recorder real fast for 10 minutes. And that was how they did it, because they had somebody else to type it. Right. But that's just individual doctor preference and what your office has capability for.
Okay. I want to change subjects just a minute. And what about using telemedicine for consultations? For example, in the past, and I think we're still doing it, we've used the robot and telemedicine for consulting neurology, pulmonary medicine, and maybe you've got a patient in the ICU. We don't have a full-time pulmonologist, and we got a patient who's not doing well. And we've been fairly successful in consulting a pulmonologist from Louisville, and they can give us some advice, and it's actually worked pretty well.
It's great. Dr. Carrie Rimmel, the chair of neurology at U of L, she started her robo-docs, back in 2009, and doing so that the doctor at the bedside, say in your ER, with a person that has a stroke syndrome, can do the exam guided by the neurologist talking to them on the screen. And they can say, they have to stat flight that person. This person needs to have the clot lysed if possible, or, there's something major happening, get them out of there. Or they can just say this, aspirin, Plavix. The other thing that they do, the pediatric side, they do pediatric neurology consults for a lot of places in the mountains and really small little facilities that haven't seen a live neurologist in many, many years. And the patient, instead of having to pack up a special needs child, the patient's mother can just take them to their regular doctor, and then they can do the visit that way. And so it really helps families who have disabled adults or children, or just special needs kids, and people that don't have to leave the comfort of their familiar places. So it's a brilliant idea, but she's been doing it a way long time. She was actually Dr. Rimmel was in the newspaper in April saying, please come to the ER if you have a stroke, because everyone's afraid to go to the ER and everyone's afraid to go to the doctor in person. And she's pleading with them so that they would not end up worse.
We've utilized the U of L Stroke Center for years, and that's been very helpful to us. And also pulmonology has been very helpful. And I hope we can expand those services, because it is a real difficult problem to get people to go to tertiary care centers for routine problems. So in our tumor board yesterday, we had a patient who had a liposarcoma, and he did not want to go back up to the University of Kentucky. And so telemedicine would be a great way to take care of that patient.
Right. Right. When you have to be there, you have to be there. But if you don't have to be there and you can get it done well, then it saves everybody gas money. It's good for the environment. And the person is really, especially in psychology, the psychologists have all said the person is much more comfortable in a home environment and opens up better. And the therapy seems to be progressing a little faster and better. Nobody wants to leave home unless they have to, I think.
Sure. Mary, how about the prospects of virtual monitoring, things like EKGs, blood sugars? I don't know, with blood pressure,
Yeah, we do that already. Like the heart failure patients, all that stuff is they have a machine to take your blood pressure. They have a scale that transmits your weight. And the glucose monitors for the people that have really brittle diabetes, they will transmit the blood sugar to your mom or to your husband or your best friend, somebody who will let you know when it's gotten low and check on you. So we do all that already as part of they call it the virtual hospital or virtual transitional care. It has different names, but we do all that stuff already. And what's best is if you can get the home nurse, the visiting nurse, and the telemedicine referring doc together on a visit, then you've got the nurse actually there asking questions and pointing out that this medicine bottle is completely full, since none of those new heart failure medicines seem to be missing from the bottle.
Well, the virtual monitoring I was thinking about can somebody stick their finger and have some gadget that will transmit the blood sugar to you?
I don't know if a finger stick will. The sensor will do it. You can transmit an EKG from your Apple Watch, pretty much.
Yes.
And there's something called Cardia, that you buy, that hardware that reads it. The virtual ICU is really interesting especially out west, because everything is so far apart. There are a whole lot of hospitals that are barely hanging on, and many more have died because of COVID. They're barely hanging on, and there is not miles, hundreds of miles. And so they hook up with a team of ER experts and ICU experts. And so the ER expert, they have the rooms wired for sound. They have ultrasound machines there. They have all kind of lighting. And the expert will talk on the microphone as you, the nurse, intubate the patient, or, you go through the code together, you set up the ventilator together. The nurse is doing all the actual touching of the patient and arranging everything. And they're directed continuously by teams of ICU docs and ER docs, that take shifts. So that has kept a lot of people alive, especially out west and in the south.
Okay, but how about the technology of a kind of a direct the information? You said you can get on a scale. Now, if you get on the scale, does that mean that the nurse happens to be in there, looks at the number on the?
No, I think they issue you some kind. There are places that issue you a scale that will send a signal. It's like a little radio. It will tell you what it has.
Okay.
It's like Alexa. Alexa hears everything you say.
I don't have that. I've avoided as much technology as possible.
There are portable scales that you can buy. They're not that expensive.
No,
and we'll give that information.
Well,
you
thanks.
can also do EKGs that way.
Yeah,
iPhone can do it. My wife has it.
Yeah.
But you got to be careful. I mean, several weeks ago, I think she had gastroenteritis and had a tachycardia, and we checked it out, and it looked like it was atrial fib, but it really wasn't.
Right. Beware the platform.
Okay. As you know, we represent, we're sponsored by a group in town here, the Kentuckians for Single Payer.
Right.
So let's look down the road a little bit, assuming that that the Biden administration is able to get something done. There are two possibilities. One is a public option, which would allow people who are under 65 to get some kind of public insurance. Exactly what that would look like obviously would depend upon whatever the negotiations were, how that would, whatever compromises are made. And the other option, which we feel is a better choice, would be Medicare for all. Where would you could put your forward-looking hat on, and where would you see telemedicine or telehealth activities fitting into either or both of those possible changes of healthcare in this country?
I think they would have to be in both of them because, first of all, they're wildly popular with Americans. They love them. The AMA polled a bunch of doctors in December, and upwards of 70% of the doctors who are AMA members said, yes, they love telehealth too, because it's just so damn convenient. And it's so quick. You can, once you're set up, you can, if somebody calls up and you're not sure if they need to come in the office, you can at least look at them and think, oh yes, you have to show up. So it helps doctors make better decisions. So I think it should be part of both of those things. And I think it will be part of both of those things, but they're going to have to figure out the payment a lot. Right now, they just kept it all the same. And, the coding just changed for 2021. So there's a lot of government finagling that's going to have to be done to continue telehealth, or we'll go back to only if you live in the country and have driven to your local health department. So
Now, did you do any telehealth when you were in clinical practice?
I did the February through May of 2020.
Well, I'm just trying to figure out how that would work. If you are in an office, you're seeing patients, X number of patients every 15 minutes or whatever the bean counters want you to do.
Right.
So how do then you go home and turn your computer on and then spend the next 5 or 6 hours doing telehealth and then go to bed at 2:00 in the morning?
No, I guess if you were trying to make money on the side, you would do that. But if you work for a big system, you're not allowed to do that. You're supposed to be there. All services, medical services are supposed to be, on their dime only.
Right.
But it's the same as seeing a person in the office, except they're not there. Is really the best way. The payment is the same. The structure is the same. It's simply at a distance. And it's really patient selection and medical judgment that make or break it.
Have you had a problem with medications? I know some of the Medicare patients, I actually saw a patient that was on 50 different medicines one time, but it's not unusual to be over 10. Do you have to spend a lot of time on that, or do you allow your nurses and then they ask you questions? How do you deal with that?
Well, Norton's has it set up so nurses' aides can check on the medicines, and most of my partners and I did not allow that because, as internists, we give a fair amount of medicine, and I wanted to make sure that was correct. So I always went over all the medicines with everybody. On these telehealth visits, this is someone else's patient who had already, I would go over their medicines just to make sure that to see if they had any idea what they were taking and why they were taking it. Very briefly, I would just read off the names of the medicines and tell me yes, 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 yes. But I think it's too important a job to be left to an aide and an assistant because they don't really know what the medicines are, or which ones don't go together and which ones are duplicates and which ones should, et cetera. You need, knowledge to be a good medicine list checker.
Now, how do you deal with the dispensing controlled substance in the virtual setting?
There's a special DEA licenses by state, but there's a special dispensation for this that we have that says essentially ask yourself whether it is more likely it will be dangerous to prescribe this virtually, or it is more likely the person will die from COVID, which was acquired in your office. That's what it actually says. So we're allowed to dispense virtually to people who have good records. They show up every 3 months and they pee in the cup when they're supposed to, and they've signed the contract, and we have run the Casper, all the rules. But it's your judgment that it's safe to do that on an ongoing basis, as opposed to make them show up and possibly get sick.
So you could see someone as a Zoom.
Yes.
Patient,
also for.
And then you would then virtually or get on the phone or have somebody in the office send their prescription for an opioid or whatever control.
Right. You would e-prescribe it, the refill. New medicines, most of the time that wouldn't come up with us, that we're giving opioids, to a brand new patient. It's just who calls it, that doesn't sound like something we would probably do.
Because it seems to me, if you were looking for drugs, that would be a great way to do it without having to get into a whole bunch of issues with people. Just call up, make up a good story.
It's a 3-day limit on what you can give, but I think if you're the ER doctor and somebody has a horribly sprained ankle and they're allergic to ibuprofen, that would be an in-person visit or a telehealth with EMS visit the way they do in LA. I can't imagine a situation, a normal primary care doctor would do that.
Do you remember one of the issues that came up with our addictive medicine was that the patients couldn't get in to see their doctor, couldn't get their
Right.
routine
Right.
narcotic,
Yeah.
and so they were going out buying it on the street. They were
Right.
getting narcotics that had fentanyl in it, and it was
Right,
ending
and
up in
dying.
overdose and death.
Yes.
Yeah, but at the same time, as we all know, folks that are into these addictions, they find all kinds of ways to get drugs. And it seems to me, just thinking about how this virtual process works, that
Right.
if you were smart enough and combed your hair and shaved and looked like you were not a down and outer and came up with a good story, you might be able to get a thing here or there. I mean, if you call four different people, four different telemedicine options with a story that seemed to be reasonable, I would say you could get four different prescriptions for
Yeah, I
controlled
think,
substance.
doctors are so frightened of overprescribing opioids at this point. And first of all, you would look at the Casper report and see how many different people had been giving them medicines in the state of, in Kentucky anyway. And then we can look at Indiana's INSPEC report. So I think that is likely some years ago, but not likely in the current climate, unless you're out to make money by giving prescriptions, in which case, telemedicine would be your gold mine.
Now, one of the other things that I've noticed from my the podcasts that I've been listening to, I sit on my Airdyne bicycle because that's what I was doing. That the telemedicine, I seems to be an entrepreneurial activity. I mean,
Yeah.
there's a lot of people out there who look at this as a way to make money. So then the question is, it's like the for-profit health insurance companies who have figured out ways to take enormous amounts of money out of the healthcare system,
Right.
as Jean has shown us, that not to be used for healthcare, but used for something else.
Right.
So I get the question is, and maybe it's a rhetorical question, but how do you balance the benefit to the entrepreneur, which is to make money, and the public or the citizens who are looking for good or better health care?
I don't know that you can weed out the bad actors unless you turn them into the state medical association and you do legal things. I don't know if that is a solvable problem because there are people who will do visits, 12 hours a day and make a lot of money doing it. But whether they give any useful advice, I don't know. But I also don't know what goes on in the exam room next door to me with my partner giving advice. I know my partner, but I don't know what advice they gave. So I don't think that can be fixed unless no one ever turns in the bad guys. The patients need to turn in the bad guys for that to happen.
Well, apparently there are companies that are figuring out different ways to do different kinds of entrepreneurial, virtual health, telehealth. There was one podcast I was listening to about physical therapy and talking about
Right.
the different ways that they're doing physical therapy, which doesn't sound like a bad thing to do at all. But they were also talking about the different ways that they were making money doing this, and so I'm trying to figure out how does that balance work? Because again, to go back to the for-profit insurance companies, they back in the 90s when all of this came crashing down, they figured out that they could get away with having 15 different programs and charging people a whole bunch of different rates, cherry picking young people.
Right.
And so I'm just wondering where does telehealth go with the example that we have of healthcare in this country, where the quote the competitive medical marketplace is magically going to make all of this stuff work.
Oh, right.
Well, which is we all know doesn't.
Right. Well, I think probably they don't do any Medicaid to begin with. they have sliding scale fees for such and such, initial consultation, second consultation. And some of them might not accept Medicare, but most all of them accept Medicare that I know of. But there's not a way to fix that because this is America. I mean, capitalism is just going to reign for a good while. They're going to want to make money. I don't know that you can do it and have a real office doctor job, a real surgical doctor job. I don't know how much time you have for that sort of thing, but I don't think there's any way to fix that unless the patients who feel like they're on the raw end of something, start pointing it out.
Well, that's why I was wondering about the public option issue and the Medicare for all issue, because if we ended up with some kind of system like that,
right?
Yeah, as 35 other first world countries around the world have, the power of the entrepreneurial for-profit insurance companies are weakened because
yes, but
there
one
is another
point
option.
The Medicare wants you to have a preferred provider. They want you to have a home base. And right now, it doesn't matter if you have a home base because of the national public health emergency. But when that's over, they're going to go back to wanting you to have a home base. So you can't just sign on and expect Medicare to pay for, some doctor out of Atlanta or Chicago. You're going to have your own person that is your person. And that would cut down on some of that. But right now, we don't care. Whoever will doctor you from afar is going to do it.
I was just listening to a program yesterday where the equity companies are already into primary care. And the emphasis is going to be on outpatient care. And the equity companies are heavily involved in the last year and are becoming more involved this year. So we're switching from hospital-based to outpatient-based, and the excess money is going to go for profit.
Well, it's going to go in the shareholders' pockets. That's where it's
Right.
going to go, the way it always works. And then they're going to make demands, putting quotas on you and all kind of horrible things is my prediction. I don't know.
Okay, Mary, we're getting close to the end of the lollipop
right.
here. Let me ask you one more question about telehealth or telemedicine and nursing homes. Do you have a sense of how it works in that setting?
It's the same as in the office. So say my patient ends up in the nursing home and the nurse is alarmed by something, and the nurse calls the nurse practitioner, who tells her on the phone to get me in a telehealth visit because the nurse practitioner is busy at the other location of that nursing home chain. So then I do a telehealth visit with the nurse at the bedside of my patient in the nursing home.
Okay,
so that's going on already.
They haul a computer or a cell phone into the
you just need an iPad or something like it.
Okay.
It's
okay, I guess
so
that's
handy for that because I know what they look like when they're well.
Has that
Oops.
worked out fairly well in the times you've done it?
I've had only done it a couple times. The people who do it all the time like it because the nursing home doctors like it because generally they go to 3 or 4 places and they're supposed to see people. There's all these rules how often you see people, and nearly all of it is delegated to nurse practitioners. But this way they can actually do more of it themselves without having to get out of their Tesla. So.
And how does the reimbursement process work with that?
It's still the same. It's the same as Medicare would pay for an in-person visit throughout this public health emergency. And when that's over, I think all hell's going to break loose about whether it will be covered the same or covered with differences. That's going to be a lot. There's going to be a lot of arguing and legislating to be done.
Okay, so the nurse practitioner calls you about the lady in room 62, takes you
Right.
on the cell phone, and you go into the room, and the lady is demented, lying in the bed, and you discuss some questions, and then you just submit your bill in the usual way. The nursing home.
Yes, I can have her like check for CVA tenderness or belly. I can have the nurse or him do something. And then you submit the bill the same way. It's considered the same as in person throughout this time.
Right. It's if you just walked in there and done that. The nursing home doesn't have any piece of that pie.
No, in the nursing home, they have a liability issue because I am not on their staff. So that doesn't happen very often. It's pretty much when someone is desperate to get a hold of somebody because nobody else is answering. And they'll talk to the patient's daughter and they'll say, well, call Dr. Lynn. Dr. Lynn knows this patient. And then they would call Dr. Lynn because the nurse is desperate. Because we're seeing them from outside. We're not practicing inside the facility. So it can be done, but nursing home liability people don't like it.
Then do you have a liability you just happen to get called and you've never seen this patient before and you're looking at them through a cell phone?
I wouldn't happen to get called from a nursing home. That's not a call I would accept.
Oh, okay.
But you can get credentialed at each nursing home.
If I wanted to, I could, yeah.
Yeah.
Okay, Mary, we want to thank you very much. This has really been great. I've learned a lot. I think Gene knew a lot more about this than I did because he dealt with it some more being down in Campbellsville. But we are very grateful with your willingness to talk with us about this. Thank you.
Thank you for asking me.
We appreciate your help.
Thank you, Gene.
Tell Gertz we said hello, and I'm really happy I don't have to be looking at his face on advertisements.
I will make sure he hears that in any magazine.
All right.
All right. See ya.
Okay.
All right. Bye-bye.
Dr. Berry, thank you very
Yes,
much.
sir.
And
Thank you, Mark.
our listeners can hear Single Payer Radio each Monday at 2 p.m., Tuesday morning at 7 a.m., and Wednesdays at 11 a.m. You can hear us broadcast live or by stream, or if you missed the episode, you can go to forwardradio.org. Want to thank our guest, and as always, Dr. Flynn, Dr. Shively. Again, for more information about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org. Harriet and Kay keep the Facebook page for Kentuckians for Single Payer current. Always some good information there. Okay, guys, till next time. Again, thank you very much.
Thank you very much. All right. Bye, you all.
Bye.